Alright, so we're going to look at some cases now that deal with zone of transition and how to describe the zone of transition and some examples and go through some of the differentials of what these lesions that we'll look at are going to be. So all these are cases, and we'll just go through them just like you're taking a case at a board review or even in real life while you're reading in front of the view box. Alright, so this is our first case. We have a frontal radiograph of the pelvis. We have this multiple areas of lytic lesions throughout the left hemipelvis and the left proximal femur. I would say this is not a geographic lesion because it's so extensive in this case, so I would call this a moth-eaten or permeative lesion. In this case, it's pretty big holes right here, so more moth-eaten in the hemipelvis, and if you want to talk about the region of the femur, you could call this more permeative. But overall, diffusely infiltrating moth-eaten lesion, multiple lytic lesions throughout the left hemipelvis and the proximal femur. We're going to think of bad things. We're going to think of Mets and multiple myeloma. Those should be the first two things that come to your mind. Really diffuse and really bad infection is possible, but I would put that lower down on the list. Really not much else to consider here, either multiple metastasis or multiple myeloma. In this case, this turned out to be multiple myeloma. All right, next case, a frontal radiograph of the humerus. We see this is a child. Physis are still open. So how to describe this lesion? So we have a geographic lytic lesion, narrow zone of transition, non-sclerotic border, which is centered in the proximal metadiaphysis of the humerus. There's a pathological fracture. There's this crescent of bone floating in the lesion, which is a fallen fragment sign. This is pathognomonic for a unicameral bone cyst. Nothing else this can be. Unicameral bone cyst, benign lesion, geographic 1B lesion in this case, non-sclerotic border, narrow zone of transition, no differential, unicameral bone cyst. That's it. Next case, radiograph of the distal tibia and fibula. We have a geographic lytic lesion, narrow zone of transition, sclerotic border, which is cortically based in the metadiaphysis of the distal tibia. Differential diagnosis in this case, primary consideration for this appearance, this location, and in this age of patient would be a non-ossifying fibroma. Non-ossifying fibromas are eccentrically located or cortically based, as in this case. They have a narrow zone of transition. They have a sclerotic border. They're common in kids. They'll fill in over time. So really good for non-ossifying fibroma. Really not much else to consider as a differential in this case. Benign lesion, leave it alone unless it's fractured, in which case they'll get treated for the fracture, but the lesion itself doesn't need any further workup or follow-up. You don't need advanced imaging for this non-ossifying fibroma. Benign lesion, geographic 1A. Next up, radiograph of the proximal femur, again in a child. We have a geographic lytic lesion, narrow zone of transition. Is there a sclerotic border or not? If you want to say this is slightly sclerotic up here, not down here, I'm just going to call this a non-sclerotic border. There is no periosteal reaction around this. If you want to say this sclerotic density right here is a fallen fragment sign, that's fine. In this case, that would make it another unicameral bone cyst. I don't actually see a pathological fracture here, but if this is a fallen fragment sign, there must be one somewhere. Centered here in this case in the metadiaphysis of the proximal femur. So another 1B lesion, narrow zone of transition, non-sclerotic border, unicameral bone cyst. Really not much else to consider here. Again, a benign lesion, no advanced imaging necessary. That's it. Next case is a radiograph of the hand. We have a geographic expansile lytic lesion with a narrow zone of transition, non-sclerotic border, which is really involving the whole, almost the whole of the second metacarpal. It extends to the articular surface here. Don't see a pathological fracture in this case. Two primary differentials here would be a giant cell tumor and an aneurysmal bone cyst. This turned out to be a giant cell tumor. In this case, I think an aneurysmal bone cyst could be an equally good differential to consider. Those would be the two main differentials in this case. So one other thing to consider, could this be expansile lytic metastasis, such as a renal cell or a thyroid metastasis? It's possible, I would put that lower on my list. Or if you had a known history of either of those malignancies, certainly you're going to consider them more likely. Um, in the absence of a history of underlying primary tumor, giant cell tumor, aneurysmal bone cyst, less likely to be a lytic expansile metastasis. This was a giant cell tumor, as I said. All right, next case, a radiograph of the pelvis. In this case, we have a destructive lesion which has destroyed the proximal femoral head. There's these small lytic lucencies through the proximal femur and the iliac wing. So this is a permeative lesion. It's destructive, destroyed part of the proximal femur. So something aggressive here in this case. We're not going to think of any benign things in this case. If you're sharp-eyed, you'll notice these lucencies right here, which are gas overlying the soft tissues. That may lead you to think that this was an infection. Patient went on to have a CT scan, and we can see there's gas within the joint, actually air within the bone, and this turned out to be a very aggressive osteomyelitis, which had destroyed the femur. Here's part of the fractured femoral head, which just kind of sloughed off into the joint space here, and obviously air within the joint. So in this case, this was a very advanced osteomyelitis. Remember, osteomyelitis can look like a whole range of things, from a geographic 1A lesion, from a simple Brody's abscess, to a very nasty permeative lesion of infiltrating osteomyelitis. Radiograph of the pelvis coned in here on the left side. We have a geographic lytic expansile lesion. It has these internal septations. It has a narrow zone of transition. It has a non-sclerotic border. It's in the inferior ramus of the left pelvis. Things that can occur here for this differential, I think, would be an aneurysmal bone cyst would be a good bet. It is aneurysmal. Aneurysmal bone cyst occur in this location. You can have giant cell tumors here. This is not the traditional epiphyseal location, but if you remember, there's an apophysis in this location, which is an epiphyseal equivalent. So you can have giant cell tumors occur at epiphyseal equivalents as well. Another epiphyseal equivalent location would be, for example, the greater trochanter is really an epiphyseal equivalent. It's an apophysis there, so they can actually occur there as well too. As all the other epiphyseal lesions can occur there as well too. So for a differential for this, I would consider an aneurysmal bone cyst a giant cell tumor. Again, a metastasis certainly could look like this from a renal or thyroid. They tend to be expansile lytic metastasis. Could this be a plasmacytoma or multiple myeloma? Absolutely. In an older adult, I think you need to consider that. Brown tumors can occasionally look like this. Those are other things to consider in your differential. This case turned out to be an aneurysmal bone cyst. I think here you're kind of stuck with a differential and have to use some history and age to help you in guiding you. This was an aneurysmal bone cyst. All right, radiograph of the femur. Here we have all these lytic areas in the proximal femur. So this is an infiltrating lesion. I would call this a permeative lesion, a diffusely permeative lesion of the proximal femur. So remember, we're going to think of nasty things in this case. So Mets myeloma, I certainly think are going to be the top two. Could this be an aggressive infection? Sure. I really wouldn't include much else in the differential in this case. Mets and myeloma are going to be the top. This turned out to be metastatic breast cancer in this case. Multiple myeloma would look identical. Now there's CT. Here we have the pelvis in the left acetabulum. We have a geographic lytic lesion, narrow zone of transition, non-sclerotic border. There's some internal matrix within this one, and perhaps there's some cortical breakthrough along the medial aspect of the acetabulum as well. This is a fairly benign looking lesion. It's geographic, narrow zone of transition. So we're going to think of more benign conditions. This one turned out to be Langerhans cell histiocytosis, which is certainly not one of the more common things you're going to think of, just to show you that it can look like this, it can look like a benign lesion. Certainly, again, in an older adult, I would absolutely consider metastasis still in this case as well. And this was a Langerhans cell histiocytosis. Radiograph of the shoulder shows us this geographic expansile lytic lesion with a narrow zone of transition, non-sclerotic border, which is centered in the epiphysis of the proximal humerus. You can see that it's thinned the cortex remarkably. It's almost all completely gone here. So we still describe this as a geographic 1B lesion with a narrow zone of transition. It's very expansile. Things in this location would be good for an aneurysmal bone cyst. It's certainly aneurysmal. Remember, with an aneurysmal bone cyst, if you're thinking of it, you like to see the actual aneurysmal component. Other lesions that can be bubbly and expansile lesions in this location would be a giant cell tumor, and this would be good for a giant cell tumor of the proximal humerus, and this indeed was a giant cell tumor. I think those are the two main differentials to consider in this case, especially in a younger patient. Again, could this be a metastasis or a plasmacytoma in an older patient? Sure, it's possible. Age is an important factor in making that differential consideration, but for this location, this appearance, I think ABC and giant cell tumor in a young patient would be your top choices. An axial CT bone window shows an expansile rib lesion on the right here. It's geographic, it's a narrow zone of transition, it's lytic expansile. There's no fracture, there's no periosteal reaction. This could be lots of things. It looks fairly benign here. Benign expansile rib lesions certainly could be an aneurysmal bone cyst. Fibrous dysplasia likes to occur in the ribs. It could be fibrous dysplasia. That's a good thought for this. This certainly could be a brown tumor. Brown tumors, you can have multiple brown tumors, and brown tumors can occur just about anywhere. Could this be metastasis? Sure, it could be a metastasis if they had a history of malignancy. Could this be a multiple myeloma or plasmacytoma in an elderly patient? Absolutely. I think those are the main things to consider here. Enchondromas usually aren't quite so expansile. There's no chondroid matrix in this case. It's possible you could throw it in there. That would probably be my limited differential for this case. This one turned out to be a brown tumor. They had multiple lesions throughout their skeleton, and they had a parathyroid adenoma causing hyperparathyroidism, which was causing all the brown tumors.